closely at a beating human heart. It is a highly contested battlefield, constantly pulled between two opposing branches of the autonomic nervous system. On one side is the sympathetic nervous system, which drives the heart's speed and squeeze. Opposite this is the parasympathetic nervous system, functioning as the body's natural slow and brake mechanism. These two forces assert their control by competing for surface territory. They bind to G-protein-coupled receptors, or GPCRs, located on the outer membrane of cardiac cells. A GPCR is a type of receptor that transmits signals from the outside of a cell to the inside by activating specialized internal proteins. To effectively perform cardiac resuscitation, a clinician must map the exact molecular pathways that start at these membrane receptors and travel all the way down to their mechanical outputs. Mapping this normal physiology shows exactly how specific pharmacological agents hijack these very same pathways to reverse clinical emergencies, like cardiac arrest or severe shock. Advanced cardiovascular pharmacology requires understanding how to target these specific receptors to molecularly tip the scales of the heart's autonomic tug-of-war. The sympathetic pathway begins with the release of the body's endogenous ligands, specifically the hormones epinephrine and norepinephrine. A ligand is any molecule that binds to a specific receiving protein, initiating a cellular response. This diagram outlines the cellular mechanisms of heart control. Here in the top left, we see these sympathetic ligands binding primarily to the beta-1 receptor on the surface of a cardiac myocyte. This binding activates the stimulatory G protein, known as GS. The alpha subunit of this G protein activates when it swaps out a molecule of GDP for a higher energy molecule of GTP. The newly activated GS alpha subunit detaches and slides along the inside of the cell membrane until it reaches and stimulates adenylyl cyclase. Adenylyl cyclase is an enzyme that acts as a manufacturing plant, and once turned on, it rapidly converts ATP into a second messenger called cyclic AMP, or CAMP. As the volume of CAMP molecules rises inside the cell, they cluster together to activate protein kinase A, an amplifier enzyme designated here as pKa. pKa acts as the crucial pivot point where chemical signals turn into ionic action. It simultaneously increases calcium entry from outside the cell through L-type channels, while also triggering a massive release of stored calcium from the sarcoplasmic reticulum inside the cell. This sudden, intense surge of positively charged intercellular calcium lowers the threshold for the cell to fire, enabling much faster electrical depolarization and far stronger mechanical cross-bridging between actin and myosin muscle fibers. Clinically, this molecular calcium surge translates directly to a drastic increase in heart rate, faster conduction through the AV node, and a much harder muscular contraction. This is the ultimate biological mechanism of speed and squeeze. When a patient experiences hemodynamic collapse, clinicians use pharmacological agonists to artificially push this beta-1 pathway. Looking at the agonist reference list on the far left, we see dobutamine. It acts as a highly selective beta-1 agonist, making it highly effective at forcefully increasing contractility to treat cardiogenic shock, a lethal condition where the heart muscle is too weak to pump enough blood to the body. Epinephrine has a broader action profile during a cardiac arrest scenario. It hits the beta-1 receptors to stimulate the heart directly, while simultaneously binding to alpha-1 receptors to heavily constrict the peripheral blood vessels. Norepinephrine, by contrast, heavily favors the alpha-1 receptors over beta-1. This preference drives strong vasoconstriction with only minor cardiac stimulation, making it the preferred agent for vasodilatory shock, where the primary failure is a severe systemic widening of the blood vessels. But we do not always want to accelerate the heart. Sometimes the primary clinical goal is to intentionally interrupt this exact sympathetic cascade to protect the cardiac tissue from overworking. Returning to the drug list, metoprolol operates as a selective beta-1 blocker. It physically occupies the receptor site, preventing epinephrine and norepinephrine from ever starting the GS cascade. Blocking the beta-1 receptor immediately halts adenylyl cyclase. The cell produces less CAMP, leading to less activated pKa, and ultimately much less calcium available for contraction. This blockade is highly effective for treating hypertension and tachycardia. By forcing the heart to slow down and squeeze with less force, metoprolol significantly reduces the myocardium's demand for oxygen. However, using non-selective blockers requires strict caution. Propranolol successfully lowers heart rate by blocking beta-1, But because it also blocks beta-2 receptors in the lungs, it risks triggering fatal bronchoconstriction in patients with underlying asthma or COPD. Controlling the beta-1 pathway, whether pushing it or blocking it, is entirely an exercise in regulating intracellular calcium levels to manage the heart's fast pedal. The gas pedal is constantly opposed by the parasympathetic nervous system, which relies on its own natural ligand, acetylcholine. Looking at the right side of our diagram, we see acetylcholine targeting the M2 receptor. Unlike beta-1, M2 receptors are located almost entirely on the SA and AV nodes, rather than the dense ventricular muscle tissue. Binding at the M2 receptor activates the inhibitory G protein, known as GI, which prompts its own energy-activating swap from GDP to GTP. The activated GI alpha subunit moves directly to adenylyl cyclase and actively shuts the enzyme down. This causes a severe, immediate drop in CAMP and pKa production, which indirectly decreases the amount of calcium entering the cell. The G protein operates a dual-action system, activating a second inhibitory mechanism through its beta-gamma subunit. While the alpha subunit shuts down adenylyl cyclase, the beta-gamma subunit migrates along the cell membrane to directly open potassium channels. With these channels fully open, massive amounts of positively charged potassium ions rapidly rush out of the cell. Because positive charge is escaping, the interior of the cell becomes intensely more negative compared to its resting state, an electrical condition called hyperpolarization. A highly negative, hyperpolarized cell takes much longer to build up enough electrical charge to reach its firing threshold. This drastically slows the firing of the SA node and delays conduction through the AV node, effectively applying a hard brake to the heart. A patient experiencing excessive vagal tone faces a dangerous surplus of this parasympathetic influence, resulting in symptomatic, life-threatening bradycardia, a dangerously slow heart rhythm. The primary pharmacological fix for this is atropine, a powerful muscarinic antagonist. Atropine competitively binds to the M2 receptor, physically locking incoming acetylcholine molecules out. By blocking M2, atropine completely prevents GI activation. The potassium channels close, stopping the rapid efflux of positive ions and immediately ending the hyperpolarization state. With the intense parasympathetic inhibition stripped away, the SA node fires significantly faster, and electrical signals easily transmit through the AV node again. Atropine doesn't actually possess any stimulatory properties of its own. It simply cuts the brake line, allowing the heart's inherent electrical automaticity to take over and drive the rate back up. In summary, the sympathetic master flow relies on beta-1 activating the GS protein. This increases CAMP, driving a flood of intracellular calcium to yield a faster, stronger heartbeat. The parasympathetic master flow relies on M2 activating the GI protein. This decreases CAMP and causes a mass exodus of potassium, resulting in hyperpolarization and a heavily slowed heart rate. Translating these pathways into clinical actions, epinephrine and dobutamine press the gas, metoprolol blocks the gas, and atropine cuts the brake. Ultimately, resuscitation is the deliberate and precise manipulation of these molecular pathways to restore the heart's vital hemodynamic balance.